If you're a prescriber, chances are you've treated someone with opioid use disorder, or you will. What you may not realize is that your actions can have a huge effect on a patient's trajectory. Opioid use disorder is a chronic, relapsing condition, but it is treatable. Medications like methadone and buprenorphine reduce overdose risk and mortality, reduce cravings, and help patients stabilize their lives. While both methadone and buprenorphine reduce mortality, methadone can only be given to patients while they're in the hospital or by a specialty clinic. It cannot be prescribed. Buprenorphine, on the other hand, can be prescribed in any setting by any DEA-registered prescriber. Let's take a closer look at buprenorphine, how it works, and how to start your patients on it safely. Buprenorphine, commonly called Bup, or known by the brand name Suboxone, is safe, effective, and can be prescribed in primary care, hospital, or emergency settings. It's a powerful medicine because of the way it binds with opioid receptors in comparison to fentanyl and other opioids. Let's take a closer look at how fentanyl, naloxone, and buprenorphine work at a molecular level. Fentanyl fully activates opioid receptors, resulting in all of the effects and side effects we associate with opioids: pain relief, sedation, euphoria, respiratory depression, and so on. Even though fentanyl fully activates the receptor, it doesn't bind as strongly as naloxone. So when a patient who has overdosed is given naloxone, it knocks fentanyl off the receptor, immediately stopping its effects. But because naloxone only blocks and doesn't activate the receptor at all, it can cause severe withdrawal symptoms. Buprenorphine is unique because it binds even more strongly than naloxone, so displaces it. Now, there's actually more biochemistry going on here, but it's pretty useful just to call buprenorphine a partial agonist, meaning it binds to the receptor enough to ease withdrawal pain and cravings, but not enough to create a high. Buprenorphine also has a limited effect on respiratory depression, making it much safer than fentanyl or heroin. Generally, patients who use fentanyl have the best results taking higher doses of buprenorphine, usually between 16 and 32 milligrams. It makes them feel normal and is relatively low risk for side effects and adverse events. The way buprenorphine binds and activates opioid receptors is why it can cause and treat opioid withdrawal. It's important to explain this to your patient and work together to develop a treatment plan. Before starting buprenorphine, it's critical that your patient is in moderate withdrawal. If you start too early, when full agonists are still dominant, you'll have to also treat precipitated withdrawal. You can use the Clinical Opioid Withdrawal Scale, or COWS, to assess your patient's withdrawal. In most populations, a score of 8 or higher typically indicates it's safe to start. Be aware that the COWS score may appear elevated in patients with acute pain, infection, anxiety, or methamphetamine intoxication. In addition to the score itself, look for opioid-specific symptoms: yawning, piloerection, and an isolated runny nose. It's also helpful to discuss how your patient typically experiences withdrawal. Ask them what symptoms they usually feel first, and which ones tend to be most severe. This will help you to decide together when to start buprenorphine and which adjunct medications to give along with it. And if your patient isn't in withdrawal yet, make sure to send them home with prescriptions for these supportive adjunct meds, along with their prescription for buprenorphine. The next step is educating your patient and starting treatment. Always start by getting your patient comfortable with buprenorphine and answering their questions. Be sure to cover what buprenorphine is, why withdrawal before starting is important, what symptoms they can expect, and of course, the rare but possible risk of precipitated withdrawal. Fear of precipitated withdrawal is a common reason patients are hesitant to start buprenorphine, and it's important to provide reassurance that precipitated withdrawal will be promptly and effectively treated if it occurs. Once you and your patient are ready, start buprenorphine by administering an initial dose or writing a prescription for them to start when they're ready. The final step, and hopefully one you won't need, is managing precipitated withdrawal. If it happens, don't panic. Precipitated withdrawal feels severe, but is usually self-limited. Typically, all you need to do is give your patient additional doses of buprenorphine, and in addition, You can treat symptomatically with adjunct medications. If your patient is starting at home, talk about all the medications they have available to them, what they can do to manage on their own, and when they might need additional medical support. Remember, buprenorphine treats opioid withdrawal and opioid use disorder. You can and should treat your patient's withdrawal prior to establishing a longer-term treatment plan. And after withdrawal is under control, the goal is to adjust the dose to manage cravings. Emphasize this with your patient and encourage them to tell their ongoing care team if they still have the urge to use. Buprenorphine is a tool you can start using today, whether you work in a clinic, hospital, or emergency setting. Learn the steps, use your judgment, meet patients where they are, and you can make a huge difference in their lives.